Dr. Blanchet, the maestro of preventing heart attack and stroke, and we're going to get a little lighter about a serious topic, but something that takes us out of the COVID mindset for a minute.
Sure.
So you made it through the pandemic. Now let's avoid the number one real killer of American men and women, long-standing premature heart attack and stroke. We know that COVID is real, but we know that we still are dying more from this, more in this country from heart attack and stroke than all COVID deaths combined on an annual basis.
On an annualized basis, that's true. Even in 2020, where for a couple of months, COVID exceeded heart disease as the number one cause of killer, for the entire year, it never did.
Yep.
The only time in the last 120 years that heart disease has not been the number one cause of death was in the influenza H1N1 pandemic of the 1918-1919. So that's the only time heart disease has not been number one. COVID didn't quite cut it, didn't quite make it.
So translation, we suck
That's right.
as a medical society at preventing heart attack and stroke.
Despite the $160 billion per year we spend trying to prevent heart attack and stroke, we still have 600,000 deaths every year in this country from heart attack and stroke at a global cost of about $400 billion.
Unreal.
It's unbelievable. And the thing that's even more unbelievable and why it requires a little discussion is this doesn't have to happen.
Yep.
Heart disease can be made to be a rare disease. You know, we don't think of ALS. We think of it as a bad disease. We don't think of ALS as being a common disease, Lou Gehrig's disease. What a horrible disease. Thank God it's rare. In my practice, more people die from ALS than heart disease. In my practice, more people die from getting hit by a car on their bicycle than heart disease.
Wow.
And so it's like, yeah, it can happen. We can do it. I mean, the way I put it is, if I can do it, anybody can do it. It's not that hard. It's not that hard.
So you just dropped a lot of things in 30 seconds there, but palling around with you for over a decade now because I want to share my story briefly and then hear your story. But the take home from the data, more women dying in this country than men from premature heart attack and stroke.
Correct.
More women dying in this country from premature heart attack and stroke than all cancers combined. Add up breast, ovarian, lung, bone, brain, still dying more of premature heart attack and stroke.
Correct.
Research dollars and emotions and pink ribbons going to breast cancer because it's dramatic when a mom dies at 42 of breast cancer. But we do heart scans in women 10 years later than men. First heart scan in our clinic per year tutelage is 40 years old. And my bad joke is if you come to my clinic from Mars and you have testes, first heart scan at 40 years old. If you come to my clinic from Mars and you have ovaries, first heart scan at 50-year-old. And that's because women are starting approximately 10 years later, and that 55 to 75 is that real not so fun sweet spot of female events.
The only exception there is if there's a family history of very premature heart disease.
Unless there's family history. And I want to hit you up about the inner heart trial and what we learned there. But then the other thing that you shocked us with from the data, first time you go and hear you as a younger doc, is for many women, 50% of them, the first symptom of heart disease is a heart attack.
Of the people who die from heart disease, for roughly 50% of them, the first clue that they have heart disease is sudden death. Boom.
Boom. It does not have to be that way. So when I asked you, how did you get the EBCT scanner to front range imaging, soon to be converting to the Siemens dual source 256 slice? And for our listeners who don't care about any of this, both of these machines have profound resolution. They can see cardiovascular plaque like no other image, and they have profoundly low radiation.
That's right.
0.7 millisieverts is what we say, and it's 4.9 millisieverts of radiation to live at a mile high for a year.
We don't bat an eye to give a woman 0.7 millisieverts of radiation to do a mammogram.
Yep.
In fact, if you don't do a mammogram, then we give you the stink eye.
Yep.
But 0.7 millisieverts is the same dose for mammograms and for heart scans, for EBD heart scans.
Yes.
And 7 times more women die from heart disease than breast cancer.
Yep.
So we can justify it for mammogram. How can we not justify it for the occasional heart scan.
And we're in Boulder County, so we love that our women come in and raise the stink eye a little bit. Are you trying to radiate me? And we've had to re-educate them that actually the mammogram is extremely low radiation. The problem with the old mammogram was too many false positives from the poor imaging.
No.
Now we have the 3D digital mammogram, and those which sees breast tissue much better, right?
Yes.
Very similar technologies for being able to see calcified plaque better, but the 256 dual source or the EBCT goes another level.
Yeah. Well, when you're imaging the heart, you have to remember, unlike a lot of parts of our body, the heart's always moving. And so the thing that's going to determine how accurate the heart image is going to be is how fast can you take this picture. And so if you look at the average 64 slice scanner, it rotates 3 times per second around the patient, which is really fast. But that means it takes a third of a second to rotate around the patient. And even with reconfiguration algorithms, it still takes a quarter of a second to get that image. But a quarter of a second, that's a fourth of the heart cycle. You're going to get motion artifact. And what most people don't realize is to do a heart scan with a 64 slice scanner, you're supposed to beta block the patient and slow their heart rate down to 60 or less.
Oh, wow.
That never happens.
Yep.
So no one does that, but theoretically we're supposed to do that. But it doesn't happen.
And that's my thing. If you're in Timbuktu and can only get a 64 slice, get it so that we can see heart disease yes or heart disease no, but you don't have a number that you can then track your plaque as a report card in future years.
You don't have a number that you can track your plaque very soon.
Yeah.
You know, if you have a number that has
Good point.
You have a number that has a 30% fudge factor in it,
Yep.
you try to track your plaque in 12 months, you're going to have much more noise than you have change. If you wait 5 years, then you can track your plaque.
Yep. Okay,
Maybe
so
3 years.
So I want to get to that because everyone knows 14% or less, and I'll highly likely die eventually of something else, but not premature heart attack or stroke. And then we talk about 10% for hives. But let's go back to young Bill Blanchet, who always loved taking on the complex mystery cases, and that's one of the reasons we get along so well is you love trying to solve problems and help people restore their quality of life. And you were doing that with autoimmunity and all kinds of fun stuff. But you were following the American Medical Association standard of care for preventing heart attack and stroke. What happened to your patient population?
Let's swing back 20 years ago. 20 years ago, before I knew much about EBT imaging, they existed, I just didn't know their value. In fact, they were called heart scans. I call them a heart scam because what I was taught, what they were telling me is that they look for calcium in the heart. And I said, well, not everything that's calcified is plaque, and not all plaque is calcified. And if you fail your heart scan, your calcium score is too high, they tell me to do a stress test. A stress test costs less than the heart scan. I'm not going to do your test. I'm just going to do a stress test. So I was happily doing stress tests, and I was ignoring the coronary calcium, and I was checking cholesterol, I was checking blood pressure, I was making decisions based on standard guidelines of the American College of Cardiology.
Risk factors.
Yeah, what does Harvard tell me to do?
Yep.
And over an 18-month period of time, I lost 5 patients, 5 friends on my watch doing what I was told I should be doing by the guidelines, by Harvard, by the American College of Cardiology. And it doesn't matter that I was doing everything right. These people are still dead. And then I was drugged.
I want to just say that for our listeners. As a medical doctor, you are given a cookbook of what you are supposed to be doing to prevent heart attack and stroke.
These are the guidelines. That's right.
These are the guidelines, and they are coming out of the old oligarch ivory tower, Harvard, now more Cleveland Clinic, and you were following them to the letter, and you had 5 fatal heart attack patients
on my watch in the 18-month period.
And only an idiot would not challenge.
Well, I'm not going to go that far because maybe I'm an idiot to have challenged. It might be that I'm the idiot to have challenged.
Well, and that might be hard verbiage, but clearly you had that 4-year-old boy in The Emperor Wears No Clothes who says, this is not working.
This is not working. This is not working.
This is not working.
And then when I was drugged kicking and screaming to a presentation on EBT heart imaging. And I went there and I listened to the presentation and I kept finding myself saying, stop, go back and show me that last slide. Is that real? Are you serious? And so at the end of that presentation, I was like, if this is real, I've been missing the ball. I need to do something. So I went to the literature and did literature research myself. And I found there were actually hundreds and hundreds of articles on the value of coronary calcium imaging. And then I'd find 3 articles. 2 of them would be research studies showing that it's hugely valuable. And the third would be an editorial saying why we should never use coronary calcium imaging.
Wow.
I was like, this is perplexing. Why are we seeing these good results and then an editorial saying why we shouldn't use it? So I started sending folks down to Denver to get their coronary calcium scores. And I was learning stuff that I could have never learned before. And so it's like, this is great. But the place in Denver I was sending to didn't accept insurance. My practice accepted insurance. And it's like, well, maybe if we put a heart scanner in my practice, we can get these under insurance. They'll be available for more people. And so I invested a truckload of money, a lot more money than I had.
You beg, borrow, and steal.
Fortunately, I have a very wealthy cousin and brother who came to the plate and said, yeah, well, we'll help fund that for you, and put up much more money than any rational, sane person should have put up for me to do this. And so I put in the heart scanner. And as we turned on the switch to you start doing heart scans, all insurance companies stopped covering it. So even though I was motivated to put it in my practice so the insurance would cover it, the insurance companies took that opportunity to not cover it.
I did not know that there was coverage initially.
There was coverage for a little while, yes.
Wow.
And so with insurance not covering it, now I'm on the hot seat. I have this test that was, the charge was anywhere from $395 to $800 for the test that was not insurance covered.
Wow.
And it's like, now what do we do? And we eked by, we got by. And then the data comes out looking at what's the value of serial calcium imaging.
Serial means repeat.
Repeat, yeah. So let's cut to the data on this. Your first heart scan, there are a number of studies that show the same thing, but let me reference the MESA heart study, the multi-ethnic study on atherosclerosis, because this is a study that was sponsored by the government, sponsored by the NIH. They actually sponsored one that was good. And they looked at all risk factors and heart disease. They looked at things like your carotid IMT, they looked at HSCRP, they looked at your cholesterol, they looked at your
blood
unique
pressure,
markers, your blood
smoking.
pressure, the whole thing. And they looked at coronary calcium imaging. And when you look at all the risk factors combined, and then look at the carotid IMT, the thickness of the inner layers of the carotid artery were twice as predictive of who's going to have a heart attack than all risk factors combined. It's like, whoa, that's big. The coronary calcium was 10 times as predictive in both directions.
Massive.
Let me explain what I mean by that. When you look at the population whose age puts them at risk for heart disease, about half of them will have a calcium score of 0. If you're Framingham low risk, that means you're less than a 1% annual risk for heart attack. If you have a calcium score of 0, you're less than 0.1% risk for heart attack. So you're 10 times lower than what Framingham defines low risks to be. If your calcium score is 0, and half the population has a score of 0, therefore we're taking a large chunk of the population saying, keep doing what you're doing, you're okay. If your calcium score was over 300, you had 10 times the risk of having a coronary vascular event than all risk factors combined would have predicted. And so in both directions, the coronary calcium was 10 times more predictive.
Wow.
On a positive direction, the IMT was twice as predictive. But this was 10 times
nothing
more
to shake
predictive.
a stick at. Yeah. So
And so it's like, this is the best thing we have by a lot.
Yep.
You know, the HSCRP, which a lot of people use, in the MESA heart study, the baseline HSCRP of people who had heart attacks was slightly worse than the baseline HSCRP, slightly better. Baseline HSCRP people who had heart attacks was slightly lower, slightly better than baseline HSCRP people who didn't have heart attacks. And so despite the fact that the MESA heart study shows essentially no value in highly sensitive C-reactive protein, a blood test, it's still being touted by Harvard as being the test you need to get.
And we've talked
heart disease.
that we'll look at HSCRP for polymyalgia rheumatica or for Crohn's or other things. It's not a bad inflammatory marker.
CRP is a good inflammatory marker, absolutely.
Not for predicting who is going to have a heart attack and stroke.
It's
worthless.
Useless.
Yeah. Yeah, that's a nicer word than my worthless. So real quick, pause button for a glossary. There was a town or a county called Framingham, Massachusetts. And they've been predominantly Harvard has been studying this town and many family members and many generations, and they have come up with these Framingham risk factors.
Right.
Follow your cholesterol to find out to try and predict who's going to heart attack and stroke. Follow hypertension, follow smoking, follow diet and lifestyle. And what we are saying is they are basically worthless for predicting who will heart attack and stroke. And maybe that's too strong of a word.
That's too strong a word.
But let's tease them out. Cholesterol is worthless. Cholesterol in large-scale trials did not show any predictive value.
Well, instead of worthless, let's use this term. They've looked at the population and say, okay, of the population, who is high risk by Framingham who has a heart? Of the people who have heart attacks, what percentage of them are high risk? What percent of them are intermediate risk? What percentage of them are low risk? Of these people who have heart attacks, what percentage of them would we have predicted that they're going to have a heart attack, therefore we need to prevent the heart attack? Actually, less than 40% of people with heart attacks would we have predicted them based on Framingham risk factors. When you look at the general population who don't, heart attacks or not, you have the same distribution of risk factors in the general population as you do in the population of people with heart attacks. So there's no difference in the incidence of risk factors in the general population and the subset of the general population with heart attacks. Therefore, it is of minimal, if any, use in actually stratifying risk. Now, if you have hypertension, if you have diabetes, if you do smoke, will modifying those things make a difference? Absolutely.
Sure.
With cholesterol, the data on cholesterol is really mixed. In the Framingham heart study, there was a small benefit with cholesterol based on high density, low density, and total cholesterol. There was no difference based on triglycerides in the Framingham heart study. There's another study in Bogalusa, Louisiana, that looked at plaque in the heart upon limited autopsy when you died. In Bogalusa, Louisiana, in the Bogalusa heart study, there's no correlation between total cholesterol, high density cholesterol, and low density cholesterol, and the presence of coronary plaque. But there was a correlation with triglycerides. Well, everybody talks about the Framingham heart study. You never hear about the Bogalusa heart study. I think both these studies have some value. And what they tell us is that following our lipids is a poor, I'm trying to avoid expletives
Trying to be
diplomatic,
polite.
is a very poor predictor for your risk for heart attacks. And so
I'm going to say it straight to our listeners. If you follow your cholesterol as an exclusive marker to wonder, do I have heart disease? Is it under control? Am I at risk of having an event? You're going to get in trouble. And I think what we're getting to, because no one can quote the literature like you, but one of the things you just said is you can have people with all of these risk factors, right? They can be a cigarette smoker with diabetes and have zero plaque. Zero calcium. You can have someone who's Mrs. Smith who works out every day. She's a Boulder triathlete, eats at Whole Foods. She's riddled with plaque.
And they looked at that. People who are Framingham high risk have 3 or more major risk factors, but a calcium score of 0 still have a very, very low risk for heart attack. People who have no Framingham risk factors and have a calcium score of over 100 have a moderate risk for a heart attack. And so the calcium score, hands down, is the best predictor of cardiovascular risk. I'm constantly looking for a better predictor. And there are people who are doing genomics and proteinomics and all kinds of things. I'm always looking for a better predictor because I get no joy out of doing heart scans. Heart scans are a pain in my butt, but they're so good I can't stop doing them.
And you do them till midnight, till the break of dawn. We were just talking about
That's right. My life would be so much better
how your
if I was
inbox
not
is
doing
flooded with 200 heart scans.
My wife would be so much happier if I wasn't doing this.
I mean, it's amazing. Like, why did you get divorced? I got a heart scanner, right? It's like, it's really the amount that you have donated to public health and improving it, because it's I call it the show me the money test, right? And I didn't know that all of these other risk factors can outfox us, right? My issue with this is you have 3 of those Framingham risk factors positive, and people start paying attention to you, and they're doing all this maybe diet and lifestyle stuff, right? And they forget the tooth abscess. They forget the apnea, right? They forget that you just had a hip replacement, and even though now you can walk again, the surgery was inflammatory, right? Then you have this other person who's like, oh, Mrs. Smith, you're so healthy, and she's got a calcium score of 300. She's a walking heart attack. And
see this all the time. I see this all the time.
This is your life that I have inherited and I have passed on to many Bastyr graduates. For our listeners, we brought Dr. Blanchet out to Bastyr. Students were crying after his talk because
amazing, yeah.
they learned.
I'll do that again sometime.
Yeah, we have to do that again because it gives me goosebumps because they were so excited that there was a data point that has such authority to tell us, are we really winning or are we getting our asses kicked with hidden causes of inflammation? And what I tell people is we kind of reverse engineer it. You get your heart scan regardless. And once we see a positive calcium score relative to your age and gender and how aggressive that is, then we have to go inflammation hunting. Right? So then we go back and
inflammation
say,
hunting and inflammation killing.
Inflammation hunting and inflammation killing. Take out that dental abscess zebra. Take out that big pink elephant in the room. Apnea, look at that surgery history and say, okay, we have to make up for lost time. Then obviously vitamin D and EPA and diet and lifestyle. But my bad joke for listeners is I'd rather you not have a dental abscess and no apnea and eat and eat hot Cheetos and drink Diet Dr. Pepper than have the cleanest diet and lifestyle in the world and have a failed root canal or tooth abscess or raging apnea.
You're not wrong.
Does that mean we shouldn't focus on diet and lifestyle? Yes, it just doesn't have a drop in the bucket.
It's not the whole story
of what chronic infection can do to your heart. Yeah. And George Washington taught us bad teeth, bad heart. Yeah. That's the deal. So I know today was just a teaser on, hey folks, if you're 40 or older as a male, you're going to get your first heart scan. Look for an EBCT or a 256 slice dual source Siemens. And we know that they're a rare breed.
What you're looking for is a scanner that can take the picture in 1/10 of a second or less. Capture the heart without motion. It's not so much the number of slices, it's the speed of scan acquisition that's going to make the difference with a heart scan.
It's like a Bruce Lee karate chop. And you get it right there. And then you have an actual...
You have a reproducible thing.
Trackable score.
And here's why trackable scores are important. First off, your first heart scan defines your heart attack risk better than everything combined by a lot. Your second heart scan tells you if you're winning or losing. So if you have a heart scan, your calcium score is 1,000. I can tell you you're at risk. You have a 1 in 5 chance of having a heart attack this coming year. If we treat this, and the next year the calcium score hasn't gone up, your risk drops from a 20% annual risk to less than 0.5% annual risk, a 40-fold reduction. Paulo Roddy did this great study back when he was at Tulane, and he had 495 patients, all had asymptomatic calcium in their hearts. All of them were put on 10 milligrams of Lipitor and followed for 6 years. During that time, a group of them had heart attacks, and that group who had heart attacks, their average annualized plaque progression was 32%. Everybody else who didn't have a heart attack, their average annualized plaque progression was 17%. But if you looked at the over-under of 15%, those people who had less than 50% annualized plaque progression had less than 0.5% risk of a heart attack, regardless of how much plaque they had. If you had plaque and you had progression, and you had a plaque score of 30 or plaque score of 1,000, you had a lot more heart attacks than a score of 1,000. But if you had stable plaque, if your score was 30 or 1,000, you had the same number of heart attacks. Across the board, there was a 17.2-fold difference in heart attacks. Looking at progression versus stability, 17.2-fold. And I say, well, why do I even bother saying 17.2? It's 17 would have worked, right? 0.2 is the amount we hope to get from taking Lipitor. If you take Lipitor, it'll reduce your heart attack risk by 20% and your risk of death by 15 to 17%. If you take high-dose Lipitor, you might reduce your risk of a heart attack by 25%. Take high-dose Lipitor plus PCSK9 inhibitor, get your LDL cholesterol down to 20. You don't further reduce your risk of coronary death. Yeah. And so if getting your LDL down to 20 doesn't do much more than 17% reduction in coronary death, what does that tell us about LDL and the cause of heart disease? LDL is absolutely a necessary ingredient for the formation of plaque. Mm-hmm. And if you have inflammation in your system and a bunch of LDL, you'll probably form plaque pretty fast. Mm-hmm. If you have inflammation in your system with very little LDL, you'll still form plaque. It'll just be slower. And that plaque will still get vulnerable. You'll still have heart attacks. So it's a rate-limiting ingredient. It's not the cause. Inflammation is the cause.
So we've been, I think, the number one referral of front-range imaging for heart scans for 10 years now.
It's possible.
It's from when I've talked to one of the employees who tracks, and I don't like that. That's not a braggadocious moment for me. I should be probably in the back end because I'm not doing primary care for, and there's a handful of people who see Jen for full spectrum primary care, but we should be behind every single primary care doc in Boulder County because every single male over 40 or older should be getting their first heart scan. Every single female 50 or older, and what I will tell you is we see people with low cholesterol with raging heart disease all the time.
Sure.
And we see people with high LP(a), one of these other supposedly vicious variables in heart disease, with zero calcium score. And we've come to this theme of cholesterol in any form, in any fashion, LP(a), small density LDL, regular LDL, will create plaque in the presence of inflammation. But the cholesterols are just powder kegs that sit dormant. The inflammation is the match that lights the wick and allows the macrophages to get triggered and start developing plaque.
And so the question is, how do we stop heart disease?
Yep.
And just a little side light here. I'm kind of tickled that when you look at the map of heart disease and coronary death,
Yep.
the place in the country that has the lowest incidence of heart disease and coronary death in the country, Boulder, Colorado. I'm not saying I'm responsible for any of that, but
damn
it makes me
right you are.
It makes me happy.
Yeah,
Okay?
yeah, and so is your brother and your cousin.
Yeah,
because
so my brother and my cousin,
and that's their legacy. What a cool thing to do with helping you.
I mean, if what
bring
we were
us the
doing,
scanner.
Boulder had the highest rate of coronary death, I feel pretty bad about that.
Totally.
The fact we have the lowest rate
Yeah.
makes me kind of smile a little bit.
I want to say one thing about that real quick, because everyone's going to go to, no, it's how clean people eat and how much they run.
Yeah.
Actually, we see triathletes with raging calcified plaque all the time from the inflammation of overtraining.
Yeah.
So,
And one of my first patients I did the heart scan on was a vegetarian marathoner who was certain he was going to have a score of 0 and was shocked to find out that he was in 90th percentile for his age, gender. Just shocked.
Yep.
It's like, that's...
So in their age group, in a room full of 100 people, 90 people had less plaque than him. He was in the top 10.
That's right.
And he was a vegetarian runner.
Yep.
Right? And that's
Thin,
because overtraining is inflammatory. And I remember the data you brought that an overtrained athlete has the same risk as a couch potato for heart disease.
Very close. That's
right? Very close, right? So we know moderate exercise has potency. We know if you're running 20 hours a week and you don't know what you're doing with inflammation, your DHEA crashes, testosterone crashes, white blood cells go low, and things like interleukin-6 that we've been talking about with COVID go through the roof, and you never recover.
And so when I say stopping heart disease is so simple, what do I mean by that? Well, here's why it's simple. In order to stop heart attacks, what you need to do is, first off, get a calcium score, get your heart scan, see what your risk is. Once you figure out what your risk is, implement an intervention, implement something to change that risk. And I can tell you what I do, I can tell you what you can tell me what you do, but the bottom line is it almost doesn't matter that I don't have to be right, you don't have to be right. If they can implement something that works, that's all that matters. Implement something and then check the heart scan again in a year or two. And if the plaque burden is now stable, what you're doing is working and your heart attack risk has gone through the floor. If the plaque burden is still going up, you need to rethink what you're doing. And that's kind of how I got to the protocols that I'm currently using, is I'd try stuff and it wouldn't work. I had you on a statin. It's like, calcium score is still going up. Let's put you on a higher dose statin. Guess what? It didn't work. Calcium score still went up on the higher dose statin.
Presented that to the Lipid Society, and it fell upon deaf ears. Crickets.
That's right. Well, it had a little conversation in the poster session. They didn't want to publish it in the journal.
That's right.
That's not going to happen.
Oh, Bill's still doing this cute thing in Boulder County where they have the lowest rate of heart attack and stroke.
Yeah. So find your heart scan implement some therapeutic intervention, recheck the heart scan, see if it works. I can tell you what I do. In fact, when you get your heart scan at Front Range Preventive Imaging, I tell you everything I do. There's no secrets to it.
No.
It's pretty straightforward.
You want
tell you
the
what
world to doctor better on preventing heart attack and stroke.
And here's the joke. It doesn't have anything to do with getting that stent. It doesn't have anything to do with getting that bypass. It has everything to do with modulating your body's physiology to stop putting the plaque down. Because it's the plaque that you're putting down right now that's going to be the softest, most vulnerable, most likely to rupture, most likely to cause a heart attack. And if we stop that from happening, the calcium stops going up, and the heart attacks don't happen. It is that simple.
So next episode, we're going to talk to people about all that. And again, I want to remind you, inflammation hunting and those little magic pills of things like niacin, fish oil, cholestyramine, Welchol, vitamin D, all that stuff. But I just want to make sure our listeners know coronary arterial calcium. That is the calcium in your crown arteries that we can see. I get my first heart scan. Let's say for easy numbers, I'm 48. Let's say I have 100. We're going to see that as moderate because of my age, mild if I had that and I was 75, right? That's an easy number for us. But you say, hey, Eric, you're 48 and you have a calcium score of 100. I definitely want one on you in 12 months. And we're going to track your plaque, right? And that's your serial scanning, right? And what I've learned is in multiple studies now, not just the MESA, but multiple studies. And again, MESA is multi-ethnic study. So finally we did some heart studies on more than white dudes, right?
Yep,
There's black people and Latino and female and Asian all represented in that multi-ethnic study in atherosclerosis. And next year we want to see 114 or less, right? We want 14% or less to say, hey, Eric, you're going to eventually die of something else.
Yeah. If you're not putting down any more plaque, you can more densely calcify an existing plaque by as much as 14% per year. If the amount of calcium you're putting down is greater than 14% per year, that means you're not only more densely calcifying existing plaque, you're putting down fresh vulnerable plaque and calcifying some of that too. And it's that fresh vulnerable plaque that's going to kill you. Get it down 14% or less, and if you give a mouse a cookie, he wants a glass of milk. If you get your plaque progression down to 14%, I want to see it down to 10 next year, and then 5 the next year, and then 0.
You bet.
But the research, that 14% is the sweet spot. Once you get below 14%, your risk dramatically bottoms out.
Yeah.
And I want to be 0, which is why I want to get it even better.
Yep.
But dramatically drops.
Yeah, you bring home a 14%, you got a nice B, a nice B plus.
That's right.
The next year you bring home a 7%, a 3%. We correct
6%.
things like dental abscess and apnea. We'll see a -6 and negative 11%. And then as we wrap up, when do you like to see? Because I know that's in the hardcore data. Multiple studies at that 14%, that magical line. We didn't make that up. You didn't make that up. It's just the data. When do you like to see it 10%? Is that a calcium score of 300? Is that when do you say, you know what, I need to get more aggressive?
The 14% or less progression annualized, or if you're a person has a score of 1,000, 2,000, 3,000, I don't want to see more than 125 absolute point increase. So those persons with a really high score, even though if 14% might be 140 point increase, I'm not comfortable with that. I want to see better than that.
Phenomenal.
So that's kind of my. Now the literature would still suggest the 14% would be nice. It's like let's do better because you're at such high risk. Let's do the best we can, and we can.
Yep.
And the joke is we can. So find a scanner that is accurate enough, that's fast enough, that gives you a reproducible thing, so you can look next year. You don't have to wait 5 years to do another heart scan. That's important. Finding one that's low radiation. That's important. And finding one that's in a center that's not using the heart scan as the wide end of the funnel to get you to the cath lab. The heart scan is the thing that's going to keep you from getting to the cath lab.
Yep.
Shouldn't be the thing that sends you to the
Cath lab is an elective stint. And remember, we'll talk more with Dr. Blanchet. The only time stints have any benefit is an active heart attack, if you're literally heart attacking. And Dr. Blanchet's saying, otherwise they'll use a heart scanner to scare you to go get catheterized, and they'll say, you need an elective or you're not in a heart attack stint. And then people think they're safe, and there's no protection from future heart attacks. So he doesn't like to plug himself. But I actually don't like plugging Front Range too much because I don't want you to get in the way of my patient population and making sure they can get in for their heart scans, because over the years, doctors are getting better locally at referring over, and everyone respects you, obviously, as the dude for preventing heart attack and stroke. But it's $195 at Front Range for your first heart scan. You can self-refer if your doctor's a fuddy-duddy and not listening to the peer-reviewed journals that are explained so well by Dr. Blanchet. Remember, he's not... he's done a couple cool studies out of his clinic, but he's using multiple data to say this is the way, this is how we're going to thread the needle. Getting down to 0.5% on anything in medicine is unheard of. There's nothing I get more excited to do than preventing heart attack and stroke under your tutelage, because the data and the results are so satisfying. It's $195. Don't be surprised nationally if you find a 256 Siemens dual source or an EBCT that's in the 500 to 900 range. A lot of places are getting down to the 300 to 500, but $195 is a steal. It's a public health benefit we get from Front Range Imaging. We are eternally grateful, and you can self-refer. Your doctor can refer you, and if you don't have a doctor who's up to speed, you can just say, hey, I want to track my plaque with this heart scan.
And from people who don't like capitalism, good news.
Yeah.
I'm not making any money off this.
Yeah, no, you don't.
This is not my retirement.
Yeah.
This is what's keeping me working.
No, what has made you money off the EBCT is that you have created a culture of arresting heart attack and stroke, and people respect your reputation for that. What loses you money, remember my nickname for the EBCT scanner was the Millennium Falcon, because it's the fastest ship in the galaxy, but it breaks down, and then you got to fly people in from Tatooine to fix this thing. And I personally know all the headache that Dr. Blanchet and his wife and his clinic have gone through, my hair raises, to keep an EBCT scanner, which is now going to be excitingly a 256 dual source, which is even a little quicker, the new Tesla, so to speak, in our neighborhood. And we would absolutely have had events without you. The amount of surprising calcium scores I find in Boulder County, the land of the healthy, is mind-blowing.
No question about it.
Thank you.
We don't want to get too deep in the weeds, but in future podcasts, we're going to discuss the steps to prevent the heart attack.
Yes.
We're going to also discuss this inescapable question of, if it's this good, how come it's not being embraced everywhere?
Yeah.
Why is that? That's a really good question, and the answer will make you unhappy.
Yes, and we'll wrap it up with, in prep for that, right now I think YouTube is hosting it. Watch the Widowmaker. Watch the Widowmaker. It's a great homework assignment for plugging into everything Dr. Blanchet brings to our county. And again, anyone's in town, especially if I love them, they're getting their first EBCT heart scan. If they're 40-year-old is a male, 50-year-old is a female, and we will front load that if you have a serious family history. Hang in there, guys. More to come on the cardiovascular series with the maestro, Dr. Blanchet. Thanks, Bill. Appreciate it.
Thank you.
Yep.